can you please explain what you mean by shared decision making?
Okay. Maybe what I'd like to do to try and explain this is to use a cartoon or diagram. Let me show you the cartoon I mean. Here's two people in a medical encounter or consultation, and what I'd like you to do is to think about what is being said here. There's a bubble here where people are speaking. I'd like you to take 10 seconds to think about this and maybe to share what you write down on a piece of paper with a colleague next to you. Could you do that for 10 seconds? Okay, so I'd like you to just talk amongst yourselves for a few minutes now, just to say, what did you write down in the bubble? I'm going to give you a bit of a pause again so that you can share that with your colleague next to you. Okay, so here's what I think is being said. Many of you perhaps might have thought that the person with the spectacles was the doctor or the healthcare professional. Well, for me, it's a patient who is using some information, let's call it a decision aid or decision support tool. They've been given by the doctor, who happens to be female in this place. And what they're saying is that having read the information, having understood it, they prefer this option. In other words, the patient has been involved in the decision. And that's what I mean by shared decision making, is trying to involve the patient in making decisions like this, where there are relevant options available to them. It's no more difficult than that, really. And there is, of course, a definition, and let me just walk you through the definition perhaps. You need to communicate together when you do shared decision making, but also you need to use evidence, the best evidence available, not just something you've read in a magazine. So here's the task, is to bring evidence from science and communicate it to your patients when you're faced with the task of making decisions. And as soon as you do this, then there's a process where you have to support the patient to get involved. Sometimes this idea of sharing decisions or being responsible for a decision is very new to patients. So you have to support them, you have to help them. For some patients, they may not feel comfortable with this, but if they see that issues are relevant to them, then they will adapt very quickly, as we've seen in research studies. So what you want to help them with is what might happen in the future, what are the harms, what are the benefits of treatment options, and what might happen if they go and choose A or they go and choose B. Now, just a few caveats to that. Of course, you need to do this where patients are accepting of the process. Some patients really feel uncomfortable with it, and that's fair enough. Or sometimes it's not ethical or legal to do that. But that's not in many cases. There are those occasions where it's not ethical or legal are quite rare actually, and in most circumstances in medical practice it's perfectly possible to involve your patients in decisions. Now I want to take you to a model which we've been sharing and developing in Cardiff. So we've developed this model, and it includes choice talk, option talk and decision talk. You'll see that there are 3 areas where we do that, and the idea is that you begin to share the idea of there being a choice available as the first task. As soon as you do that, then you have to describe the options in more detail. And when you try and do that, it's often the case that you don't remember the detail. What are the probabilities of harms and the probabilities of benefits? And that's the time when we need, as practitioners as well as patients, to rely on some decision support, some tools to help us. And here we've described 2 varieties of tools. The short ones, which you use face-to-face, and then the long ones, which the patients might read or go to the internet, or go and watch a DVD. The long tools that help them discuss these options with their family. The idea here is to move people along from what are their first idea of what they prefer to their very well considered and very well informed preferences of what they would like to do. So you're moving people through a process of what the psychologists call preference construction. All in the space of deliberation, supporting people to deliberate about what's best to do, to think about it. And here's the thing about shared decision making, that as soon as you give people choices, they need a bit of extra time. So this kind of process doesn't usually occur in one consultation. It occurs across 2 consultations at least, and maybe more. So the idea of giving information needs to be separated from the idea of considering it and bringing it back to make a decision. And this may change your practice. Here's a slide that demonstrates where we were in the first days of shared decision making. This is a nurse showing a patient how to use a laser disc in Boston. Very old technology now, not available anymore, but basically the idea is the same. This patient is considering much more information about the pros and cons of having an operation on his prostate. So this was in the late 1980s when these tools were developed by the group in Boston. We as a research group here in Cardiff were also involved in making decision tools. And the area has grown over the last 10 years. Here's the results of the Cochrane review, led now by Dawn Stacey in Ottawa, kind of just summarising the evidence of how these tools have led to good results. Patients have greater knowledge, they have more accurate risk perceptions, they have greater comfort with decisions, they take part in decisions more, and actually in some situations when you use tools like these decision aids and decision support tools, it leads to patients taking less procedures, electing to have less surgery, for instance. So that's where this field has got to in terms of testing these interventions.
What is the MAGIC programme?
Okay, so the MAGIC programme is a programme that's been funded by the Health Foundation in London and has asked us to take on the field from the kind of idea of making these decision tools to getting them used in practice. And that's one of the difficulties, I think, is that there's been a lot of research on developing these tools and putting them into clinical trials, but there's been much less research on how to do shared decision making in real practice. Here's, for instance, a tool that we did on the web called Prosdex, and another one called Amniodex, and we also did one called Breastdex. So these 3 tools we've designed and tried to get people to use them. But here's the difficulty we've found, is that by putting these very elaborate and very nicely designed, I think, tools on the web, we're finding that it's very difficult to get doctors and health professionals to refer patients to them. So we're facing a bit of a problem. Here's an illustration of the MAGIC programme, which was to try and involve hospital and primary care teams in trying to do shared decision making in the real world. We involved a number of teams in ENT and breast and so on, and we tried to involve the whole organisation, the hospital, the primary care, to get the senior management of those organisations interested and engaged. And we also tried to do a social marketing programme with that organisation, so that we tried to get the whole organisation to take this on board.
Thank you. What do you think is the way ahead in terms of implementing shared decision making?
What we found, I think, is that when you take this to clinical teams, you get a lot of resistance. Here's a slide that shows you some of the resistance we found. We get doctors who are opposed, they're skeptical, they're indifferent. They say often that they're doing it already. So It's actually when you go and take shared decision making into the clinic, in Portugal, certainly here in Cardiff, you find a lot of resistance. Here's another set of challenges. People complain that there's not enough time, that it's too difficult to get the evidence in front of patients. All these problems quickly come in front of you. So our view is that, just to go back to this cartoon for a moment, is that the solution is to try and develop very simple tools, which we call option grids in Cardiff, which the patient is using here, very small tools on one side of A4, which you can give to the patient in the consultation, and it doesn't take more than about 2 or 3 minutes for them to use them. And in this way they get the idea, oh yes, there's kind of 2 things or 2 or more things I could possibly do here. Here's an example of an option grid which we've developed from BreastX, the breast cancer tool. The idea is that we have the 2 options, A and B, on 2 columns, and we ask questions that the patients frequently ask. So if you organize the information in this way, what you see, you can direct patients to say, what are the chances of the cancer coming back, for example in this slide. You can compare what it's like in mastectomy with what it might be like in lumpectomy, and you see the difference in rates, 5 in 100 versus 10 in 100, and immediately the patient is able to compare these 2 options. Here's the other change would be whether or not you have radiotherapy or not in these 2 choices. So these tools, these simple tools, allow people to compare the 2 options much more easily and more quickly. And we are finding that using these tools in the consultation leads the patients to understand the choice and then to seek more information. Back to the model again. Basically what we're doing is try to put the elements of this model into place using a short tool as well as a long tool in the space of deliberation. Now, what I've done there is to show you, if you like, the ideas that we've had over the last decade, from making very complicated tools and almost going back to become simpler, to making shorter tools that you can use in the clinic as a way into the patient and their family seeking and wanting to have more information to make the choice. It does lead, I think, to shared decision making requiring maybe a second visit, but for difficult decisions, for important decisions, I don't think this is a bad thing. It leads to the patient being more satisfied, much more confident in their decisions, and probably leads to less cost in the healthcare, and certainly to less medical legal complaints and kind of problems with patients feeling that they regret the decision they've made. Thank you very much for asking me to talk to you in Lisbon. I hope you have a good conference.